So thank you very much for the invitation. Thank you for the introduction. I'm very happy to be talking to all of you today about the Learn More, Breathe Better program at NHLBI, the National Heart, Lung, and Blood Institute, and what you should know about COPD on this COPD Awareness Month and International COPD Day. As you just heard, I'm a program director in the Division of Lung Diseases at NHLBI, and my portfolio includes COPD, other lung diseases, and tobacco, including e-cigarettes. So I have a lot of research that I oversee, from basic science all the way up to large observational cohort studies. So first, some quick facts about COPD. COPD stands for chronic obstructive pulmonary disease. This is the 6th leading cause of death in the US. It was the 3rd leading cause a few years ago. Some things superseded it, including COVID, but it is now the 6th leading cause of death, and it accounts for nearly 150,000 deaths per year. Millions of people have been diagnosed with COPD, but it's also estimated that there are millions more that have COPD but may not know it because they have not been diagnosed by a doctor. COPD is a leading cause of disability in the US, and estimated that 6% of US adults have been diagnosed with COPD, again, with many millions more that have not been diagnosed. COPD is a serious lung disease, and it's a chronic lung disease. So it develops slowly and over many years and decades. And what COPD does is it makes it hard for you to breathe. So what is hard for you to breathe? It means less air is flowing in and out of your airways. Now, your lung is made up of airways, which are basically tubes that the air flows through, and air sacs or alveoli, that which is where the oxygen is exchanged for carbon dioxide in the blood. So there are several ways that COPD can develop. One is that the airways and the air sacs lose their elasticity. They lose their ability to bounce back after being stretched out. And you can imagine that that would be a problem for breathing, because breathing is an active process. Air is coming in, air is going out, and you need some kind of elasticity to be able to push the air out when you breathe out. Otherwise, you end up with air trapped in the lungs, which is a problem. Another way that COPD can develop is that the walls between those air sacs, between the alveoli, can be destroyed, making basically holes in your lungs. So that's what emphysema is. The airway walls can become thick because they're inflamed. They can become swollen, and that narrows the airway. So of course the air has more trouble flowing in and out of a narrowed airway tube, basically. Or the airways can make more mucus than usual, which can also clog the airways and make it more difficult to breathe. So if without treatment, people with COPD will gradually lose their stamina, their ability to perform daily activities, and generally their quality of life will go down, because it's harder to breathe and it's harder to have energy and do the things that they would want to do. There are 2 main conditions for COPD, and sometimes people use these interchangeably with COPD, but they are sort of 2 different conditions. The first is chronic bronchitis. This is primarily affecting your airways, those tubes that the air is flowing in and out of. And this is caused by an inflammation and excess mucus in those airways. And chronic bronchitis typically presents as a cough, a lot of phlegm in the lungs. In addition, COPD can include emphysema. And emphysema is those damaged air sacs, those holes in the lungs that you can see on lung images sometimes. So between these two conditions, people, this is where COPD comes from. So people with COPD can have primarily chronic bronchitis, primarily emphysema. Usually there's some sort of combination of the two. Common signs and symptoms of COPD include coughing. So sometimes you would call this a smoker's cough, a classic sign of chronic bronchitis. Shortness of breath while doing normal everyday activities like walking up the stairs or walking a hill. Inability to breathe easily or to take a deep breath. Excess mucus production, that phlegm in the lungs or sputum that you can cough up, or wheezing. The main risk factor for COPD is smoking. So smoking is responsible for about 8 out of every 10 COPD deaths. It's the #1 cause of COPD, and 75% of COPD cases are occurring in people with a history of smoking. Now, that doesn't necessarily mean that they're currently smoking. Even if you quit smoking, but you have a long history of smoking, you're still at risk of developing COPD as you get older. About a half, just as I said, about a half of those cases are current smokers and a half are former smokers. But then as many as 1 out of 4 people with COPD have actually never smoked. And it's still a bit of a mystery what the risk factors for those individuals are and why they're developing COPD. But of course, smoking is not the only risk factor. Another risk factor is long-term exposure to lung irritants or pollution in the air, secondhand smoke, chemicals, dust, fumes in the indoor or outdoor environment, occupational exposures. These can also increase the risk for COPD. And your genes can increase your risk for COPD. So a large portion of your risk actually comes from things that you can't control, your genes. There's a particular condition called alpha-1 antitrypsin deficiency, and as many as 100,000 Americans have this mutation, and those individuals can get COPD even if they have never smoked or have long-term exposure to pollutants. COPD affects men more or women more easily than men. So about 6% of women and 4% of men have been diagnosed with COPD. So even if 2 individuals, a man and a woman, have the same exposures, the same basic genetic makeup, the women are going to be more susceptible to developing COPD. The prevalence of COPD is more concentrated in rural areas. It's about twice as prevalent in rural areas compared to urban areas. And I think that's probably due to a mixture of factors, including smoking prevalence, other exposures, occupational environmental exposures, socioeconomic factors, and maybe some factors that we don't know about yet. And in particular, there's a higher prevalence in the Southeast and areas of the Mississippi and Ohio River valleys. The racial and ethnic group with the highest prevalence of COPD is American Indian and Alaska Natives. So 1 out of 10 in that group have been diagnosed with COPD, whereas for whites or non-Hispanic Blacks, that's about 5%, for Hispanics 2%, and for Asians, it's 1%. COPD can be diagnosed using a number of different ways. Primarily, COPD is diagnosed in the doctor's office using a technique called spirometry, where you basically blow into a machine and it measures the airflow. You can also diagnose COPD or learn more about your COPD with imaging of your lungs, so a chest X-ray or a chest CT scan, or by actually looking at how well aerated your blood is with a arterial blood gas test. However, as I said, it is estimated that millions of people don't know that they have COPD, and they have not yet been diagnosed. And there are many reasons for that. Not everybody has a physician, but physicians, when asked about why people might not be diagnosed with COPD, report that patients don't always give them the information that they would need to do that, to make that diagnosis. So patients don't always fully report their symptoms. A lot of the time, the patient is going into the doctor for another health issue, and their breathing problems don't necessarily come up. Or the patient doesn't fully report smoking history because they don't want to deal with the judgment that may come from that. As I said, the primary way to diagnose COPD is with spirometry. This is a breathing test, checks how well your lungs are working. And as you can see on this image on the right-hand side, this man is breathing into a spirometer. So you basically breathe into a tube, and it measures how fast and how much air you're able to exhale. This shows how healthy your lungs are, and if you have COPD, and how serious it is. And this can be used to help your provider know if you have COPD even before you show many of those classic symptoms of COPD. COPD currently has no cure, but the disease is treatable and manageable in most cases. So there are multiple medications that can be prescribed. Pulmonary rehabilitation can be used and is very successful at improving quality of life of COPD patients. You can make lifestyle changes, most important of which is quitting smoking if you're still smoking. Or in extreme cases, there are surgical treatments that can be looked into. However, there are a lot of just important lifestyle behavioral things that you can do to help get ahead of your symptoms and try to limit the rate of worsening of the disease. So the most important, number one, I'm going to keep saying it over and over, I've said it already, the first is to quit smoking. If you're already smoking, smoking cessation is the only real way that we have that's proven to decrease the rate of COPD worsening. So it really is the best way. Even though former smokers can later develop COPD, quitting smoking is the best thing that you can do to limit how bad your COPD gets. In addition, it's recommended that somebody with COPD avoids pollutants, visits their doctor regularly, stays current with vaccinations. That's very important to limit the respiratory diseases that the individual is experiencing, and to have the support of their family and friends to deal with the stress and anxiety and depression that may come with COPD. The barriers to prevention, early diagnosis, treatment, management of COPD need to be overcome to slow the progression of the disease. Those who have COPD or know someone who has COPD want to know more about the disease. 50% are interested in getting more information, and particularly they're interested in knowing more about medications, knowing more about pulmonary rehab, and knowing more about healthy living and lifestyle changes that they can think about to improve their disease and their prognosis for their disease. So I'm just going to very briefly discuss an exciting area of research that has developed over the last few years in COPD, which is a new group of patients who don't actually have COPD. They are tobacco-exposed people who have symptoms but preserved lung function. So these were discovered in the Spirometry study, which is one of those longitudinal cohort studies of COPD patients, smokers with and without COPD. And the Spirometry study found that in their study, 50% of the people who had a history of smoking, that means they're either smokers currently or they're former smokers, So 50% of the people with a history of smoking but preserved lung function, meaning that when they took a spirometry test, they got a normal result or a close to normal result, still had significant respiratory symptoms. And many of these patients were basically treated as if they had COPD by their doctors. They were prescribed COPD drugs, even though technically they didn't have lung obstruction. They did not have chronic obstructive pulmonary disease. In taking these, this discovery and these patients into consideration, NHLBI funded a trial called the Redefining Therapy in Early COPD, or RETHINK trial, where they took those patients, these patients with symptoms but preserved lung function who had a history of smoking, in a randomized blinded placebo-controlled trial. They tested whether their symptoms would improve when treated with your typical COPD drugs. That is what is called a LABA, a combination long-acting beta-2 agonist, and combined with a long-acting muscarinic antagonist, or a LABA-LAMA. And what they found is that these patients did not improve in their symptoms when treated with these drugs, even though many of these patients or patients in this group were being treated with these drugs by their physicians. It didn't improve their symptoms. So this is a new group of patients that we really need to know more about to understand how to treat them. So I talked a little bit about pulmonary rehab as one of the most important treatments that you can have for individuals with COPD. Pulmonary rehab can help people with chronic breathing problems to live and breathe better. And 2 out of 3 people who participate in pulmonary rehab do report positive outcomes in such areas as reducing their symptoms of COPD, increasing their ability to participate in physical activities, improving their life functions, and improving their emotional health. So how does pulmonary rehab work? So a group of healthcare providers, including doctors, nurses, and physical therapists and respiratory therapists, will design a pulmonary rehab program that's tailored to the needs of the individual patient. And this includes education and actually exercises that the patient can do. Results vary, of course, but in many individuals, this improves the understanding of the disease and how to manage it. It increases the strength of the patient and allows that patient to partake in a more active lifestyle. It improves their mental health. And it gives them opportunities for peer support. So if you're doing pulmonary rehab in a group of other COPD patients in a group class, that provides that sort of peer-to-peer support that patients might benefit from. So the program includes, as I said, exercise, and that includes improvement of stamina and flexibility. So also it may include breathing exercises, occupational health advisement, so instructions on how to find easier way to do everyday tasks, smoking cessation advice and aid, psychological counseling, and nutritional counseling. So where does pulmonary rehab stand now in the US? Now, there are limits to who has ready access to pulmonary rehab. Pulmonary rehab is generally done in a particular facility that patients would need to have access to or travel to. If they live far away from a facility, if they're in a very remote location, such as many of those rural areas that I told you earlier had high prevalence of COPD, it may be difficult for those individuals to get access to pulmonary rehab. But in the last couple years, we've all realized that video telehealth is a really promising way to get access to medical care, even for people who may have difficulty traveling or may be living in a relatively remote area. So NHLBI recently funded a very small preliminary trial that tested how well pulmonary rehab through video telehealth, where the patient stayed at home and did the pulmonary rehab through their computer, how well that stood up next to your sort of traditional center-based pulmonary rehab. And what they found was that these were basically very comparable treatments, that there were similar benefits to both the center-based rehab and the telehealth-based rehab. So NHLBI is now funding a larger and more rigorous trial that is going to look at this more carefully. But it's possible that in the future, many of these individuals will be able to access pulmonary rehab through at home through their computers. Everybody's interested in COVID-19 still, I think, still floating around. What do we know about COVID-19 and COPD? Well, first of all, COPD does not make it more likely that you will, more or less likely that you will contract COVID-19. So there's no significant difference in the rate of infection between people who have COPD and people who do not have COPD. However, if you have COPD and you become infected with SARS-CoV-2 and you come down with COVID-19, there is evidence that suggests that your outcomes are more likely to be worse. So significantly higher rates of hospitalization, significantly higher rates of ICU admission, and significantly higher mortality with COVID-19 patients who already had COPD compared to those who did not have COPD. So that all of that is to say that everybody should get vaccinated against SARS-CoV-2, but patients with COPD especially should make sure that they're vaccinated. COPD patients should also get the flu and pneumo vaccines and use their inhalers as they did prior to the pandemic. But it's very important that COPD patients are fully vaccinated against these diseases. The awareness of COPD has gone up in the past 10 years, but still a quarter of adults in the US have never heard of COPD and don't know what it is. And 3 out of 10, approximately, people with COPD symptoms are undiagnosed and untreated. So we still have a lot of work to do in terms of awareness and reaching out to the US population, teaching them about COPD so that if somebody does maybe have some of the symptoms of COPD, they know to go to their doctor and get treated for it to improve their life. The federal government a few years ago developed a national action plan to deal with the ongoing problem of COPD, and this was led by NHLBI. Millions of dollars are spent on the direct and indirect costs of COPD care and the consequences of COPD. And this is expected to increase as the population ages in the coming years. So Congress requested that NHLBI lead the development of a COPD national action plan. So with input from the broad COPD community, this was developed. This is the first ever blueprint for a unified fight against COPD. And it provides a comprehensive framework for action for those with the disease, those who care for those with the disease, and those who treat those with the disease. And you can find the COPD National Action Plan online. It's at copd.nih.gov. There are 5 main parts to the COPD National Action Plan. The first is focused on patients, their families, and caregivers to give those individuals support on the front lines of dealing with COPD. The second part of the plan is deals more with the healthcare workers, so improve the prevention, diagnosis, treatment, and management of COPD, improving the quality of care that's delivered to them. The third is to improve our surveillance of COPD, so to really know to a finer degree who has COPD in the nation, how COPD is developing, and what changes may be occurring in the US. The fourth is based on scientific research, clinical research, to better develop therapies, develop prevention techniques, management, treatment, diagnosis of COPD. And then the fifth is policy oriented. So to translate these recommendations into actual public health care actions. And individuals or groups who are involved in implementing the COPD National Action Plan can record their activities using the COPD National Action Plan Community Action Tool. And you can find that at cnap.nhlbi.nih.gov. And you can see what groups are involved in implementing the plan and what kind of activities are being supported by all of these different groups. Including this group here, including the Learn More, Breathe Better program, including NHLBI, including all of us, what we're doing to help implement that plan. And these are some of the featured programs. So these include the COPD Foundation, the Emphysema Foundation, Breathe California, of course, Learn More, Breathe Better, and the CDC and the American Lung Association. So a lot of organizations are committed to implementing the COPD National Action Plan. You can also learn more about COPD by using the resources of the Learn More, Breathe Better program. So again, this is a program supported by NHLBI, and it provides free resources for patients, their caregivers, and for the medical community. So it includes animated videos that educate on COPD, fact sheets, and other resources like infographics and various forms of social media. And in addition, there's resources for healthcare providers, including a toolkit for providers, different teaching tools, and handouts that can be given to patients. So here you can see some of the resources that are available in the Learn More, Breathe Better program. Other resources that you may be interested in. So of course, Learn More, Breathe Better, you can find that at copd.nhlbi.nih.gov. And the National Action Plan I already talked about, as well as the Community Action Tool. Another program that I wanted to highlight is the COPD Caregivers Toolkit, which was formed through a collaboration between NHLBI and the Respiratory Health Association. And this gives just really great advice for caregivers of patients that are living with COPD. So I recommend that you take a look at that at nhlbi.nih.gov/COPD-caregivers. So here are some of the references that I cited, and thank all of you for listening and for inviting me to come speak about this.
Thank you, Dr. Postow. I have been monitoring some of the questions that have been coming in through the chat. And so I wanted to just pose a few of those for you and see if you can share any insights in these areas.
Great.
So the first question we have is, what are the latest ideas in treatment? And when might those treatments be available?
So the good news is that research is ongoing, and we're learning a lot more about this disease. So I would say that for individuals with COPD, the future is bright. We are improving our understanding of COPD. We're developing novel treatments. There are huge advances in the scientific realm in terms of genomics, molecular assays, developmental biology, imaging technologies are improving at an incredibly rapid rate. So we're learning more about what the structure of the lung is and how those changes occur. We're developing new animal models, including the ferret, which is maybe a better model for COPD than your typical lab rat or lab mouse. So all of these techniques together are allowing scientists to develop more ideas for COPD research and potential treatments. And we're also supporting a number of different trials and other scientific research looking at long-term effects of pulmonary rehab and how that can be used to improve the COPD outlook.
Thank you. Another question along the lines of treatment, beyond sort of the emerging areas in treatment, how is COPD generally treated?
As I said initially, that we do not yet have a cure for COPD. So COPD treatment, the goal is generally to relieve the symptoms, prevent complications. So you want to prevent sort of these respiratory exacerbations that put you in the hospital. You want to limit those, increase a patient's general quality of life, allow them to stay active, improve their mental health. So a treatment plan would typically have a number of components. So number one, I'm going to say it again, quitting smoking if the individual is continuing to smoke. That's absolutely the most important thing that you can do. Avoiding other inhaled irritants, other gases or particulates in the air that can exacerbate the disease. Visit your doctor regularly when you're supposed to, and then follow the treatment plan that you get from the doctor. Second most important to quitting smoking is to make sure that you're up to date on your vaccines. That means flu shot, pneumo, COVID-19, all of those. And to talk to others with COPD. So there are a number of different support groups that you can join, and that's incredibly helpful for developing community and improving mental health with the disease.
Thank you. Someone asks, could COPD patients receive lung transplants?
Yeah, so they can. It is not a typical, or this would be sort of a very, very last resort. More often, the surgery that is done on a COPD patient is lung volume reduction. So the problem with COPD, or if you have emphysema, is, like I said, you have these holes in your lungs and the air sort of gets trapped in there. So with these sort of very severe cases, sometimes what can be done is you can sort of reduce the size of the lungs. You can basically cut out a section of the lung, making the lung smaller, and that actually improves the symptoms because there's less tissue there that needs to, you know, bounce back from breathing in. And so even if the elasticity of your lung has decreased and you have these holes in the lungs, it has less space for the air to go. So that has improvement on some symptoms of very severe diseases.
Thank you. Someone asks, can you have emphysema without having COPD? And if so, when did science learn that these are two separate conditions?
Yeah, so that's interesting. So emphysema is referring to the holes in the lungs. It's referring to the expansion of the alveoli. And generally speaking, if somebody has severe emphysema, they will probably have COPD. COPD is generally defined based on how well you breathe. So in practice and theoretically, you can have those holes in your lung, but you still breathe well enough to not sort of meet that threshold diagnosis of COPD. And we do have a significant amount of data that as people age, this is a normal thing to happen, that you will develop these holes in the lungs, and what that's called is emphysema. But if that's not extremely severe, you may still technically have normal breathing and not have the disease as it's defined.
Thank you. Someone asks, if a loved one had COPD, what's your number one piece of advice for them?
Well, so the number one piece of advice is to talk to their doctor and learn what medications are available and what kind of care is needed to deal with their disease. But also, maybe equally important is lifestyle changes. So again, quitting smoking, getting your vaccines, trying to stay active and do as much as you can to slow the progress of the disease by learning more about the disease.
Thank you. A few more questions that have come in. If someone has a chronic cough, what would you advise them to do?
Well, so the first thing that they should do is go to their doctor and learn more about it. So, and then the doctor has a number of treatments that they can use. So they could be put on the LAMAs or LABAs, or a combination of the two that I discussed previously. But there are other treatments, and I think the doctor would need to hear more what kind of cough is it? Is it a wet cough, a mucousy cough where you're coughing up sputum? Is it a dry cough? Is the cough deep in the chest? Is it in the throat? So what I would advise is to go see your physician and learn more about what kind of cough it is and see what kind of treatments are available.
Thank you. Here's a question. My husband has COPD, and I'm looking for information to help me as a caregiver. Do you have any resources?
Yeah, so I would really highly recommend that COPD Caregivers Toolkit that I mentioned earlier. So again, that's nhlbi.nih.gov/COPD-caregivers. There's a lot of just really fantastic information in there that help deal with all different aspects of dealing with sort of the life of a COPD patient as a caregiver. So what kind of questions to have ready for the doctor's visits, what to do if the patient needs to go to the hospital, how to deal with your own mental health, because being a caregiver is, I know, incredibly draining and very, very difficult. So there's a lot of great information there. Caregivers can also get information at the National Institute on Aging's website. So this is a sister institute to NHLBI, also part of NIH. And so you can go to the National Institute on Aging's website. That is nia.nih.gov.
Thank you. And then our last question is on a bit of a personal note. Someone's asking how you chose your career path, how you got into all of this science of COPD.
That's a really interesting question. So as the introduction said, I'm trained as a molecular biologist, and that's my background, very basic cellular biology. And I didn't want to continue on the classic sort of bench scientific career path because it was just very stressful and didn't really fit my general personality that well. So I moved to NIH, and when I looked at the different institutes and I learned about what NHLBI and the lung division were doing, I realized that the lung is just an incredibly interesting organ in its own right. And there's a lot of questions involved in the lung, and that there was a lot of interesting work to be done. And then through COPD, through having research about COPD in my portfolio, that's how I got interested in the tobacco and the vaping and all of that research, which has been just really fascinating and very fun.
Thank you. That's very interesting. Thank you, Dr. Postow. That wraps up the questions that have been posed in the chat. Thank you so much.
All right. Thank you.